patients. And we also, if we're unable to do that, we use our connections within the local area to send people out to specialists if for whatever their whatever their medical needs are. Another sister part of HopeWay is HopeWay Psychiatry and Associates. This is a fee-for-service outpatient practice. Most of our psychiatrists who practice in HopeWay Maine also work over in Psychiatry and Associates. We also have some therapists over there. We see a range of psychiatric pathologies, and we offer individualized psychiatric services, evaluations for the community, and also medication management, follow-up appointments. And we also do a fair amount of psychotherapy over there. And you can see our website below, as well as our number. If you have any questions, please reach out to us. So I wanted to start by kind of talking about how we conceptualize mental health. If you think of kind of an old school Venn diagram, and you think of three circles, you think of a biological piece of the picture there. This is genetics. This is your chemical makeup. This might be a medical problem that is kind of contributing to a behavioral health problem. This might be what you put in your body, if it's substance, alcohol, or illicit substance that can kind of impact your mental health. It might be that. It might be something that's not in your body, a deficiency in a vitamin or a thyroid hormone or something like that. The biological piece kind of contributes to our emotional, psychological, and social well-being. And that's kind of the part that we really target with medications and other behavioral things like exercise, diet, that can kind of really affect that. But we also know that life experiences, trauma, abuse, any stressors, even if they're good stressors, can kind of impact how one's mental health is in the time. And then what that's filtered through, their psychology, how they see themselves in relation to the world, how they interact with others, how they might handle stress, and what their coping skills might be. So when we think about how to support a loved one, it's really important to kind of understand all of the factors that are contributing to someone's mental health. All right, so this cartoon here is about the stages of change. And before I get into that, I'll say supporting a loved one is a humongous topic. We could probably each talk for an hour and a half on this. So we each chose to briefly speak about something that that we thought would be the most helpful. It's certainly not all inclusive of ways that you can support your loved one. And I chose stages of change because I think it's important to understand how people decide when they need to change something, how they go about the process of change, and how we as loved ones can kind of step in and help them sort of progress through that. So you can see this gentleman here has probably put on some COVID pounds. So he's thinking of working out. He's imagining himself shedding some of those pounds. He's reading a bit to kind of prepare for that. He starts to kind of exercise and eat right. And an unfortunate part of nearly all change in behavior is that sometimes we sort of revert or relapse back into old behaviors. This is pretty true for almost all of our mental health conditions. They are conditions in which the propensity or the possibility of relapse is always there. And so the real trick is to kind of get into that point where you're in that maintenance phase and trying to continue to maintain the positive behavior that you're doing, but to also understand what to do if you notice someone's kind of relapsing into a behavior. So for the purposes of this talk, changing behavior might be trying to cut out a negative behavior. This might be someone, example, who uses substances, or someone who's not taking a medication or something like that. Or it might be trying to get them to engage in a positive behavior that they're not currently doing, such as eating right or exercising. So to briefly define these changes, we think of kind of a pre-contemplative state as someone who's really kind of unaware of certainly a problem in their current situation and unaware of kind of the need to change. The next step is contemplation, which is where most of us kind of hit a wall. We may be aware that there's a problem, and we might be aware that we need to change something and what we need to change, but we're unable to kind of get ourselves started or get the momentum going. Once we kind of get to that point, we go into the preparation phase where we kind of intend to kind of take action. We prepare, we might read about certain things, we might make plans to do things, and then the real action starts where we start to practice and then eventually kind of maintain that behavior. Like I said in the previous slide, it is not uncommon to kind of fall back into old patterns of behavior. I like to think of people having a slip versus a slide. And so the key is to kind of recognize if you start to see those old behaviors coming back. If you kind of go back to the chart, you don't have to go from a relapse to pre-contemplation all the way through contemplation and around again. You can insert yourself right back into action. You know what you need to do. It's about recognizing that slip and preventing that slide. So I like to think of it as a contemplation hurdle. Like I said earlier, it's once someone kind of understands a need to change, how do you get them into that sort of preparation phase? I realize the audience here are mostly family members, perhaps people who themselves struggle with mental health problems. I'm speaking to you about a type of interviewing that we as clinicians and psychiatrists use. Not that I expect you to be a replacement for that, but just to kind of show you the type of language we use and kind of the strategies we use to get someone to change. And one really interesting thing that we use is motivational interviewing. And it's not like Matt Foley from Saturday Night Live, trying to get people up there, motivating people and trying to scare them into something or trying to, motivate them yourself. It's actually trying to evoke motivation from within, from the individual. And by the process of kind of asking open-ended questions and kind of reflecting back to them what you hear, it's almost as if they're coming up with their own idea and motivation themselves. And that's much, much more powerful than if you're trying to persuade someone to do something, or if you're trying to shame them into doing it or using other types of motivation. So a couple of key things about motivational speaking is that it really sits between listening and not really giving any direction and being more formal and giving direction and advice. So essentially you are trying to, again, ask questions, give feedback to try to collaboratively come up with a problem and a desired behavioral change and kind of help that person find their own inner motivation to do that. You really want to empower them. So again, it's just drawing out, finding their own meaning, importance, and capacity for change. It's very respectful. And I think one of the things that we need to think about and when we're trying to support people is we know that our own intentions in trying to help someone are genuine and good-natured, but we have to accept that maybe the strategies that we use may not be the best for that person. And so we sort of have to understand what works, what motivates that person best. And we have to be open to the idea that sometimes if we don't do that, the strategies we may think are working might actually hinder someone's progress. And I know Dr. Bozman and Erin are going to talk a little bit about some of that later, about how to use certain language to do that. But it just reminds me to say that because you want to be very respectful and curious and very positive when you are engaging someone in this kind of line of thinking. So useful situations in which we use this are situations where people are really, really ambivalent about changing. They have mixed feelings about whether they want to change or not. They also may have confidence that, not a very low confidence that they're able to, even if they know they need to. They may not have the desire or the will to want to do that. And importance, it's kind of a play on words here, but really they kind of, they kind of don't truly appreciate the benefits of what change they would make, or really understand that their current behavior has a lot of disadvantages. And so an example of that in mental health would be perhaps someone who is not taking their medication despite their doctor's recommendation that they have to continue that indefinitely to prevent relapse. They may not see the disadvantages of taking a medicine or of not taking a medicine because they don't feel bad currently. But they might not benefit, see the benefit of actually taking medicines, because it's again a preventative type of thing. And so these situations are really helpful situations to kind of take approaches of motivational questioning. Couple of more of the core components of this, and then we'll get into kind of some specific ways in which you can engage someone. So the kind of the key techniques that you would use is ask open-ended questions in the beginning. You're doing this for a reason. You're doing this so that they in their own mind can kind of come up with and speak about what are the problem areas, what are the areas that they need to change, what behaviors do they need to change. And then you want to affirm that. You want to both positively and negatively with sort of affirming statements. So for example, if someone says, the guy that's in the cartoon there, if he says, I really need to, I'm not feeling really good. I know I need to lose some weight. It's been difficult during the pandemic because I got thrown off my routine. An affirmation would be like, yeah, it's been really difficult. I can imagine that for you, it's been difficult to kind of eat healthy if you're not able to kind of go out to the store like you used to, et cetera. So you're kind of reflecting back to them and giving them some affirmations that shows them that you're listening and you can kind of understand their position. You really want to go after positive affirmations, any type of win, if you will, that they've done, any step that they've even taken that's even remotely close to making a change. You want to kind of grab onto that and reflect that back to them. And then when you kind of, when you kind of identified a problem and perhaps a solution, you want to kind of reflect that back to them. So, in that example, you may say, well, what I'm hearing from you is that you'd really like to lose some weight. And I can understand it's been really difficult to do that because of the way in which we've all kind of had to hunker down during the pandemic. But we've identified some ways, maybe if you start walking a few days a week, and maybe if you start to eat less fast food and that type of thing, that we can do that. So you kind of join in with them, you reflect, and then summarize kind of what the plan is. And then you may exchanges of information. This might be creating an accountability kind of partner, if you will, kind of, telling them, that you'll be checking in with them, or asking for updates, those types of things. So very, very brief, but very important for us to kind of consider how we talk to people. And I guess if I wanted you guys to take away one point, it would be the motivation that comes from within is going to be the most successful in driving the change. Motivation from external sources, whether that be from fear of negative consequences or trying to be persuasive, are much, much less effective. So what I'm going to do now is I'm going to stop my screen share so that all three of the panelists here can answer any questions that you guys have. And I would love for you guys to submit some questions so that we could answer them for you. The one that I see here is, I'm just going to read this out, that this is a person who says that they have family members that struggle with basic communication. Given that, if it were distilled down to one or two things that are the most basic and most likely to move the needle, what would those things be? So if I understand this correctly, what strategies or what information could we give to loved ones? Very, what one or two nuggets would be the most basic things to help your loved ones understand the difficulty of making changes, and also perhaps the right way to sort of approach you or have a dialogue about that. I'm going to see if Erin or Dr. Bozman has any thoughts on that, because it might kind of tie right in with some of the things that they're going to say later.
My initial reaction is like validating and having empathy for the experience. So I'm going to actually jump into that when we go into communication. But I think also just making a statement like, hey, I understand that this can be really difficult. And really actively listening and trying to hear you before making a response. That's my initial reaction. So I don't know if I'm on the right track there, Casey.
Yeah, I think to piggyback on that, I would say it's, just acknowledging and validating that, that you're going through a difficult time and that they're here for you. I think from their perspective, just acknowledging, or being aware that, to my earlier point, relapses and slips are kind of expected in some respects. It's we don't want to provide a pessimistic view of one's prognosis, but and it doesn't have to be that way. It's just that when an opportunity like that, when a situation like that arises where there may be a relapse or something like that, I believe it provides an opportunity to learn. And if you can collaborate with your loved one and kind of help them get right back into that action or maintenance phase and learn from that, then I think that's a kind of a silver lining. Couple more questions. I think a really good one that I saw about medications says, my son will not comply with medications because he's, quote, fine. He's been under the care of an ACT team. For those of you who don't know what an ACT team is, it's a assertive community treatment team. It's essentially kind of a team, a mobile team of doctors and social workers and therapists, sometimes pharmacists and nurses, who really wrap around and support people who have chronic and persistent mental illness. When you're dealing with people who may not have, who think that they're fine, may not feel like they have a need to take medications, I think instead of going directly at how can we get you to take your medications, you may start to ask them, well, what have you, when you're on your medications, what have you noticed has gone better? Or pointing out, maybe you don't want to take your medications, but I notice when you do, you don't go to the hospital. And so if you can kind of ask open-ended questions or direct them a little bit to understand some of the correlations with being on medicines and being off medicines, you begin to sort of show them and get them to kind of be internally motivated to take them, not just because you want them to, but it's because it keeps them out of the hospital or something like that. I don't know if that's helpful or not.
I agree with what Dr. Marra has said about this. I think the important thing is not to get into a battle with them, because that just tends to shut off communication. I think trying to come up with concrete examples of how they were doing and things that they were able to move forward in their life when they were consistently taking the medication, and how that may have gotten off the tracks when they stopped, is important to kind of put facts before their eyes without being argumentative about it. Because once you get into an argumentative stage, it's just shut down at that point.
Yeah, I agree. And it's, it's difficult. That's one of the biggest challenges that we have in with that particular population, who kind of need to be on medicines indefinitely, but they don't necessarily have the insight to sort of be aware that they need to be on that. So with that, I am going to go to the next phase. And of course, we have about 15 minutes at the very end here, or whatever time we have remaining, to answer all questions. So unfortunately, can't get to all in each segment, but we'll try to sort of get a representation of questions from each segment at the end too. So I'm going to pass this along to Erin Dos Reis, our fabulous primary therapist and licensed clinical social worker.
Thanks, Dr. Marra. I really appreciate that. I am going to be focusing on communication today, which actually I saw come up in a bunch of the questions. So hopefully we'll be able to answer some of the questions we didn't get to in the first segment with this. So over my slide, sorry. I just wanted to start with some common communication techniques. What I hear a lot from my clients here at HopeWay is the frustration that they work so hard to learn how to communicate their boundaries, wants, needs to their family members. And then when they leave HopeWay, they have a hard time communicating because their loved ones don't know the same communication techniques that they're learning. So I always encourage people to, just tell their family, educate them, like tell them what's working for you. This is a basic common communication technique called an I statement. So both of these techniques are technically healthy communication techniques. I statement is I feel emotion when you situation, and then asserting ourselves next time, can you fill in the blanks. Gottman's XYZ statement is very similar, but the I feel is at the end. And so what we talk a lot here is kind of rolling the dice, and I think people are saying too, sometimes communication doesn't even get to that point because the other person really shuts down. These I statements are heard in DBT Endearman, which is an interpersonal effectiveness communication skill. So really causing someone to take a look and say, like, what are the objective facts of the situation? How did I feel? What am I trying to assert? Can I reinforce? Being mindful, appearing confident when they communicate, and negotiating when appropriate. So the I statement, like I said, is the most basic form and a really good place to start. Because if you come with you language, like you do this, you do that, it doesn't tend to land well because the other person becomes really defensive. The next thing we want to do in communication, and it sounds like a lot of you were already doing this, and asking questions, and I brought up the importance of validation. I hear a lot, and this came up a lot in family groups we used to do, that providing validation and empathy just didn't come naturally as the next step in communication. So you can really get far with someone when they say, like, I'm really struggling, instead of immediately being like, what can we do to fix it, right? So I really care about you and I want you to feel better. Just saying, like, yeah, it sounds like that's really hard right now. But also recognizing that sometimes it is really hard and we have to do that stuff anyway. I just listed out some of the common boundaries here. I like to look at, porous boundaries as Swiss cheese. So this is when our loved ones kind of we're trying to start to set boundaries, but information keeps pouring through and can lead them to be into some unhealthy dynamics. So I saw in the question before, like, somebody brought up codependency and how that affects the way we communicate with our loved ones. So I'm going to be addressing that in the next couple of slides. So I hope that answers your question. Rigid boundaries, I want you to think of like a brick wall. There's no negotiating. Who's in is in, who's out is out. We're not having any movement with who's getting close to us in our circle of trust. And then we have our healthy boundaries. So those are really talking about negotiable boundaries. It is important to keep in mind that sometimes like a rigid boundary can be healthy. Like I have rigid physical boundaries at work. That is healthy for me, right? It's healthy for my clients. Something that a lot of my clients really struggle with is the idea that their family is policing them. And I think it's really important for me to remind them, like, hey, people are typically end up in that policing dynamic because they care about you and they didn't really know what to do before. And so it's like an anxiety response. And so really working together through the relapse prevention plan, which Dr. Bozman will talk about, of, hey, what can they do? Let's empower them to know how to support us. Because if they don't know what to do, a lot of times they're just grasping at straws trying to figure it out. And that can lead to that policing behavior or our loved one really feeling smothered. So some things that we can do for the loved one to become increasingly more dependent is to kind of have like scheduled mental health check-ins. So it's an agreed upon time saying like, hey, I'm not just going to show up at your door and be like, how are you? How's your mental health? But maybe we'll have a phone call a couple times a week where like we know we're going to talk about mental health, and it's agreed upon in advance that if you're struggling, you will reach out to me outside of those scheduled times. We want them to feel like they can come to us and also sometimes loved ones then start to feel on edge because they're like, oh my gosh, is this person going to start this like heavy conversation with me at any point in time about my mental health? So that policing dynamic and fixing for our loved one can create this triangle. This is called the dreaded drama triangle. And it's a dynamic between three different people, although some people look at the persecutor as life, but the persecutor is the problem, right? The victim is the person who doesn't feel like they can manage or handle the persecutor. And then we have the rescuer who comes in and solves the problem for the victim. So the victim has like a life is happening to me mentality, and it can be a learned helplessness if the rescuer comes in, kind of like codependency, like the person in the question asked, and fixes the problem for the victim every time. The victim, the next time they're in distress, is just going to go to the rescuer and say, hey, I don't know how to handle this, so I need you to handle this for me, right? So what we try to do with therapy is change the victim. And I know victim has a very, like, in our culture, negative connotation to it. So I want to really be mindful that the way they're using it is like a victim of life, like life is happening to me, and changing it to the idea that I'm creating the life that I want. So the persecutor sets expectations and boundaries in advance, and they take on the role of the challenger. So they're still promoting the creator to grow. And the rescuer, by asking those open-ended questions that Dr. Marra was talking about, becomes more of a coach. So instead of being a savior, they're now a supporter. And this is where we really want to be mindful, because we can't, just like Dr. Marra was saying, do the work for our loved ones. They really have to do it for themselves, but we can support them in it. If we try to do it for them, it can create like more of like what I call the voluntold dynamic, where like somebody comes to HopeWay and they didn't really want to be here. They're only here because they kind of were told they had to come. And so they might not invest as much of themselves into the process. So this is the other triangle. So when we change those roles from the victim to the creator, they now have the idea like, I can do it, I can take on, I can create the world that I want. The coach says, how will you do it? I'll support you in it. How do you think you should address this situation? And then the challenger, again, sets those boundaries and expectations in advance and promotes growth. This is something I hear about a lot with families, is they say, like, I feel like I'm walking on eggshells around my loved one. Like, I don't really know. It just feels like if they're going to be explosive at any point in time, like I have to adjust my life to make sure that they're doing okay and they're stable in that moment. And what's really important, I think, a big message that somebody with mental health diagnoses, and a lot of people know, is, yes, we are struggling and we can be explosive, of course, and we want to go back and apologize, but also having a mental health diagnosis just doesn't give us permission to act however we want, right? Where a lot of times, not everyone, as we talked about earlier, with people who are maybe not open to taking medication and things like that, but if you're open to attending therapy, CBT, DBT, DBT's distress tolerance skills in particular can be really helpful with those explosive episodes. That will get better with time, utilizing those things. So boundaries and expectations are really important in the home, right? Like knowing what the consequence is going to be if they break a boundary. And then it's important to have an if-then plan. So if I'm trying to support my loved one, I want to know, like, if this happens, then what? So it can be really difficult to approach a loved one if you notice that they are having signs of a mental health episode, whether that be mania, whether that be depression, right? Like a lot of times when people are isolating and they're depressed, maybe they're not showering on a regular basis, their eating habits have been altered, their sleep habits have been altered. So if I went to my partner and said, hey, I noticed that you haven't showered in a couple of days. How are you? Are you okay? Do you need anything? that can land a little bit different than like, yeah, get up, like you haven't showered in a few days. It's like, you really need to go take a shower, right? Having it be more of like that open-ended question check-in. And if you have the relapse prevention plan that's been reviewed by both of you, then you can reference it as well, because it's about knowing what to say. And I really encourage you to have a conversation with your loved one. Like, if I notice that you're struggling, how do you want me to approach you? And keeping in mind, like, oh, what can I do? Like, so if I approach you and you say, oh, let's call my therapist together, or can you call my therapist and make an appointment for me? Then I really want to make sure that I have a release of information, or I have the information for the therapist. Like, I want to remove as many barriers as possible in advance. And I'm also at questions. So I'm going to.
So Erin, I want to jump in here because for a handful of questions, there's a similar theme about an adult child or a person who doesn't really want to respond to feedback that they're giving, or does not see their behaviors as problematic or the same way that other people do.
Yeah.
And one of the things I want to relate to you as a loved one of a person with mental health, you have to decide what your boundaries are as well. Because oftentimes the frustration that we feel is because we're giving, or we're trying to rescue or trying to save, and the other person, it feels at times like they take advantage of that, or that they're, excuse me, disrespectful of it or not appreciative. There are limits for what you can do for somebody. You know, there's an old psychologist joke about how many psychologists does it take to change a light bulb. It's one, but the light bulb has to want to change. And you're trying to facilitate them, to go back to Dr. Mars, you're trying to facilitate them to move from pre-contemplation, where they don't think they have a problem at all, to even beginning to think that it may be an issue. Whereas if you confront them head on with action items that they need to, boom, you need to do this, you need to do this, they're not at that stage and they're not ready for it. So the motivational interviewing that he was talking about is helping somebody move through the continuum. And you often see this in substance use problems, where you think the person may have an addictive problem. They think they're a social drinker. And it's helping them begin to see the issues that it's creating. So that was wordy. So sorry, Erin, didn't mean to interrupt.
No, I appreciate you managing the questions while I wasn't able to look. So I saw a specific question related to the empowerment dynamic and the drama triangle. Can someone be the challenger and the coach? Yes, it depends on the situation typically. Like, you can become a challenger and then in other situations be a coach, typically not at the same time. But a coach does promote growth, right? If my child does not take problem with some of her behaviors and choices. Sorry, I'm just reading the questions.
Somebody also asked if they could be, a person could be IVC'd to HopeWay. We're a voluntary program. You know, one of the premises that we operate on in general, although Erin has talked about, you know, being somewhat coerced to come in, but, you know, we accept the premise that our clients want to be here and are actively wanting to change.
Looking at some of these other questions, I see, like, how can you help someone see themselves as others see them? I think that's a very, like, it's a long process, because basically they're struggling with automatic negative thinking, which is also habit. So you're building new neural pathways in your brain in order to challenge that automatic negative self-talk. And Dr. Bozman, let's talk about the time frame that can take. So I can add him in there, but it typically can take really up to like 18 to 24 months to break a habit. So also, I think just really supporting them in doing that, like giving encouragement, because it's really frustrating. And I personally find that that's when most people give up on therapy, is when it can take longer for that emotion piece to catch up with the logic when you start challenging that negative self-talk.
I think to add to that, Erin, you know, getting someone to see themselves as people see them
Mhm.
can be, on one hand, perhaps someone who underestimates their value, if you will, and has that negative self-talk to what you spoke to. It can also speak to people who have what we would say is maladaptive or unhealthy personality traits, that ways of interacting with people, ways of managing stress that are off-putting or create chaos and conflict in their life, and they don't really see their role in it or their problem. We would use a clinical term called egosyntonic, meaning that their behavior seems to kind of fit with the way they see themselves. They don't see it problematic, as opposed to ego dystonic, like I recognize that I'm part of this problem. And so one of the benefits at HopeWay is that group therapy is really, really helpful for both of those scenarios. You can get sort of instant feedback from 10, 12 people, both positive and negative, to kind of challenge whatever thoughts you have. Again, to challenge this negative perception of that you have of yourself. These other people are saying, no, this is how we see you. If it's more of a conflictual situation and someone says, you know, I'm not at fault here, and 8 or 10, 12 people say, actually, we all kind of see that this is our reaction to what you just said or what you did, that can be really, really powerful, much more powerful than one particular person saying it to them.
And then I had one more question that I was going to answer from the chat box, just about somebody returning to an unhealthy relationship. Like, now is probably the best time to answer that question. It typically does take someone about 7 times to leave an unhealthy relationship. And my encouragement to you would just be, if you're able to, if you're willing to manage that, is to just be open and just say, like, we're here for you when you're ready to leave. Because a lot of times people do feel isolated in those relationships, and if they are very unhealthy, that has caused them to cut out friends and family members and isolate themselves further and further, then they feel like they don't have anywhere to go. So if you continue just reminding them, like, hey, I'm here for you, and whenever you're ready, it will give them a safe place to leave that relationship. And on that note, I believe that we're at time for our break. Right?
Correct. Yeah, if
Okay.
everyone wants to take about a 10-minute break, we'll resume a little after 5:50.
Thank you.
Okay, well, welcome back, everybody. I did want to take a moment. I tried to type the answer, but I'm not sure it went through. Somebody asked a question earlier about ACT teams. ACT, and Dr. Marra defined what the service is, but that's a service that is usually accessed through Medicaid or state-funded clients. Unfortunately, if your loved one is on your insurance, most private insurance companies do not fund ACT teams. And I know that's very frustrating. You may have to investigate through the state or what we call the LME, the local management entity, about how you may be able to get your loved one involved in ACT. I hope that answers your question. All right, so I'm going to spend some time talking about relapse prevention. Obviously, when we're talking about relapse, we're talking about somebody who has made a fair amount of progress to recovery, or is at least functioning much better than they were when their symptoms were much more acute. And let me see about advancing. Okay, so these are kind of simplistic, but I think they make a very good point. What this graph is showing is that oftentimes we have the expectation that somebody's going to start working on a mental health problem, and you're just going to see this linear progress, that they're just going to, you know, week after week, you're just going to see them get closer and closer to where they're supposed to be, or where they were functioning before their mental health illness. But the fact of the matter is, and oftentimes clients have that, but it's not unusual for loved ones to have that expectation as well. But what we typically see is that recovery is an up and down process. And if you were to put a trend line to this, you would see progress over time, but they are going to have slips, as Dr. Marra said, and they are going to have setbacks. There's going to be times just in life that things are more stressful. The important thing for you as a loved one in supporting this person to recognize in this, and the way I present this when I do groups, is that B is not A. So it's often, as a loved one or a person suffering with a mental illness, they have that downturn and it feels like nothing has changed. And it's important to recognize and validate what has changed, because if you feel beat down and defeated, oftentimes you start giving up on the very things that were helping you progress in the first place. So it's very important as a loved one and someone who's supporting them to point out the progress that they have made and the changes that you have seen, and to encourage them to sort of get back on the horse and not let old behaviors and habits take back over. This is a little more complicated, but this is what I call the relapse prevention graph. And so if you look at the green line, that is like a steady state. Somebody has made some significant progress. The blue line is life happens. You have good days, good weeks, bad weeks. The important thing to recognize here is this small circle and the large one. So the red line is, it's just not a bad week. Either they or you start seeing early warning signs appear or emerge, and they don't come back to that better level of functioning. You see things starting to slide. What I try to drum home to clients that are here continuously is, it is always easier to address that when the slide or the slip happens, not waiting until you need to come back to HopeWay, or you need to be have a hospital stay again. If you address some of these things, you get in to see the psychiatrist if they feel like the medications aren't working as well as they used to, or they stop going to their therapist and you see them slide a little bit, but taking action to get back on track and doing that early in the process. All right, so Relapse prevention is a difficult process. And one of the reasons is one of the fundamental elements of relapse prevention is accepting that you have a mental illness. Oftentimes what happens is people have a first bout of depression, they do some work, they take some medication, and they recover, and they think, I'm over it. And they well may be. However, if you've had a mental health issue, you are in a position where you're more susceptible for that to repeat. And there was a question earlier about, my child stops taking their medication, they won't take their medication, they argue me. That person has not accepted that they have a mental health issue and that it needs to be managed, and it needs to be managed over time. It's difficult, it's a difficult process, and it's also paradoxical because you want the person to acknowledge that this is something that they do need to manage, but you don't want them to adopt a sick identity, or this is something that I can't improve, or I can't live the life that I wanted to live. Because oftentimes, and what we find here with a lot of our clients, frequently people do obtain a level of functioning that allows them to live their life, allows them to flourish, allows them to pursue their goals and their dreams. But they also have to be aware that they have to maintain those things they did to get to that point. They just can't stop because, as Einstein said, if you do the same thing and expect different results, you're not going to get anywhere. So acceptance can be a very hard and difficult process. There was another question where somebody indicated that they don't want to wait. Their child has gone into crisis mode a couple times, and they would like the child to go into a higher level of treatment while they're actually doing a little bit better and not always addressing it as a crisis. That again boils down to acceptance and trying to help them understand the advantages of caring for themselves. And part of that is accepting that they need to. Recognition and awareness. This part of this goes to early warning signs. When we have this group here, our relapse prevention group, one of the things that clients are encouraged to do is to share their relapse prevention plan with their loved ones. And in that plan, they have hopefully worked on their triggers and their early warning signs. And by sharing that with you, it makes you aware of some of the things that they've discovered and that they're aware of that indicate they're moving in the wrong direction. So if you haven't gone through a program like this, sitting down and talking to your loved one about, when things start to turn, what are some of those signals that you start to feel? There are many things, and these are individualized. There's some common themes that we see. Erin touched on earlier about, this person hasn't showered in a few days. We frequently see that personal hygiene slides. That doesn't mean that that's going to be true for every client as an early warning sign, but that's a common one. Awareness is really talking about being aware of the situations that provide you with some resilience. For example, being around people who are supportive. If it was a substance use issue, being around people who are aware and are willing to have fun without drinking or using. But it's being aware of the situations and the things, the stressors that will push you towards relapse. And then, of course, anticipation and planning is anticipating those situations and planning for them. So a common one that we see here is somebody went away to college and they did okay for a little bit, and then they started to develop a mental health issue and their grades slipped. They started never going to class or leaving their room or other signs. They come through, they enter treatment, they make gains, and there's a plan to go back to school. Well, that's great, but you need to anticipate, and they need to anticipate and think about, well, what were some of the things that led things down the wrong path to begin with? What can we do? You know, how can you signal to us as loved ones supporting you that you may need some help from us? So thinking about those situations, it can be simple as going to a family reunion where the rest of the family drinks and argues, and that is a trigger for that other person, and planning those situations and planning to support them in those situations. So these are the 3 fundamental tenets of relapse prevention. We talked about warning signs. These are some of the more common warning signs that we see across clients. I like to think about those in areas of self-care, of socialization, of achievement, and of joy. So if you see self-care starting to slip, that's probably a warning sign. If you see them starting to withdraw from class or from calling in sick a lot to a job, that may very well be a warning sign. If you see them starting to isolate from people, you as the loved one or friends that they commonly associate with, or if you see them giving up on things that they have done consistently to make their lives fun and interesting. But I want to stress that warning signs, these are common ones, but there are individual warning signs, and talking about with your loved ones about what they see and what they think these warning signs are and what they want you to do should you believe that you see one of those. One of the diagnoses that we see here frequently is bipolar disorder. And that is a disorder where it is often believed that you should take your medications really for the rest of your life. People who struggle with that will often relapse. But in a bipolar disorder, when they move to the manic side, it's often very difficult for them to see the early signs of mania because they feel better than they have in a long time. And it's hard to turn away from that. If they share those warning signs with you early on and you ask them about, well, if I see this, what do you want me to do? How do you want me to talk to you about it? Then you at least have a platform to bridge it. Okay. When you're trying to support somebody's recovery, it was commented on earlier about feeling like you're walking on eggshells around it. And clients here often, when you say, what's some of the things that family members or loved ones do that trouble you? Well, they walk on eggshells around me. Well, that's great, but what about when they just come right out and say, hey, you haven't showered in 2 days, what's going on? So talking to them about how they want to be checked on. You know, if they're isolating in the room, where's the boundary there? You know, how much is too much? And trying to do that when they're in a reasonable state of mind can give you some guideposts to follow. So talking to them and asking them about it and empowering them to sort of set the limits is always helpful. If you see warning signs and you haven't done some of this up front, you do need to tread gently. You need to talk to them about how they're doing, and not the more direct you go at it, oftentimes the more defensive they become. So just saying, hey, I love you, I'm concerned about you, how are you doing? Rather than saying, you know, I'm kind of noticing that you're struggling here, because it'll shift them into a defensive mode. again, asking them about their warning signs, and then asking them what they want you to do when you see one. When I have groups here, I've often asked this question: what helps? What can you tell your loved ones that helps you? And in all honesty, a lot of times I get silence and they're not really sure. I get things typically like, I don't want them to walk on eggshells around me, or when I come in the door from treatment, I don't want to be grilled with 30 questions. You know, are you okay? Is it helping? What did you do? You know, believe it or not, days are long here. And I know we have art therapy and music therapy, and this is a nice campus, and other places that people get treatment are hopefully empowering and nice places for them to be. But our days here for clients are stressful. They're working, and the groups can be tough. Sometimes when they get home, they need some space, and you need to give them time to kind of incorporate what they've gone through and what they've heard and what they've talked about in the day, and make kind of peace with it so that they're in a position to talk about it. And also, given the graph that was earlier, it's not a linear process. So, you know, what you really should be doing is, in my opinion, is supporting them in treatment, encouraging them to keep working, asking them directly, how can I help? What helps? And the second bullet point on here, they probably have a really good idea of what doesn't help. When I rephrase that question in group, I get a lot of answers. And so they know the things that you do that trigger them. Those of you who don't understand the term triggers, those are things that evoke, they can be positive or negative, but when we're talking about mental health, they evoke negative emotions or responses. They're not necessarily a relapse, but if you're being triggered all the time, they can contribute to relapse. So knowing what their triggers are and how you can discuss this with them, how they can take the feedback, is important in not triggering them. This is my final slide, and it's busy, but I use this in groups in relapse prevention. When I'm in a group, I can ask the question or make the statement, if medications were the answer, how many of you would be here? And nobody raises their hands. So I want you to notice in the upper left-hand corner, medications is there. And it is oftentimes a very, very important element of recovery and relapse prevention. However, most of the clients we have were on medications before they came here. And so what this puzzle is showing is many of the other things that a client has to begin to think about. And these, the majority of these came from clients here. I started bringing this with one or two things filled in on here and asking them for their feedback. So you can't do all of this at one time. It's overwhelming if you try to take it on. What I try to say is look at these and put a check mark by things that you may kind of have under control, because you may have good relationships and good support and relationships, or you may be going to therapy. And then pick one or two that maybe you're not doing as well at, and think about how can I make some progress on those. But the theme of this is the more pieces of the puzzle that you get in place, the more complete the picture of recovery becomes. And the more things that you sort of check off this and say, yeah, I've got that, the more you're putting the odds of recovery and staying in recovery in your favor. So I don't in any way want to poo-poo or talk down medications, because they are an important part of recovery for many people. But you have to take the rest of your life in You know, if you're here, you're in therapy, you're taking your meds, and you're in hostile, abusive relationships, the likelihood of you recovering is actually pretty low, and the likelihood of you relapsing is very high. So I think that's my last slide, and that'll give us some time for questions. So if Dr. Marra and Erin, if you've had a chance to review these while I was prattling on, please jump in.
Yeah, one really good question was, how do I believe it's something about how do I support my loved one who identifies a need to change, comes up with a plan, but is unable to kind of either follow through or implement that plan. Without having details, it's difficult for me to be very specific, but in general, you may want to kind of look at what the expectations or what the goals are that that person's setting up, and you may need to kind of temper those expectations a little bit. Oftentimes people are really good and enthusiastic when they start to get into that action phase, preparedness and action phase, and that kind of really quickly kind of goes away after a couple of weeks, and it's hard to maintain a behavioral change if the expectations are too high. So I would rather you focus on starting really low and going slow and getting them kind of the repetitive confidence of achieving whatever goals they are, rather than having a very high high bar.
I used the example when I was talking about somebody going back to college. And, one of the things that I often caution clients about, it's wonderful as a loved one, a parent, when you think your kid is ready to go back to college. But I would rather them do a little bit more work and be in a really solid position than rush back and then have difficulties again, because that setback is even more difficult than the first. So and I can tell you, I've had 3 kids go to college and had one struggle a little bit with it. And there was a part of me that wanted to get them back there. But there was also that part that, they have to be ready to go back, and they have to be able to deal with this, not only the stressors, but the pressures and the peer pressures that come with school as well. So I agree with Dr. Marra that small achievements, small goals should be acknowledged and celebrated and supported. And there's a comment on here that sometimes just reminding them that you love them can be helpful. I think that's extremely helpful. It's a lonely place to be. When I've talked to parents, sometimes you get the impression that, well, I saw them when they were doing better. Why can't they just do that? Or I don't know, they seem to kind of like being stuck, or like they're not having fun. And you need to disabuse yourself of that belief, because that is part of what frustrates you and then leads you potentially to deal with them out of frustration. They're not having fun. It's not a fun place to be. So letting them know that you love them and that you want to help them and that you're willing to try with healthy boundaries in place is a very important part of healing.
I would add to that to explicitly also tell them, especially in the context of a slip or a relapse, explicitly telling them, I'm not disappointed in you. I'm not angry with you. I just want to support you. Let's learn from this experience so that we don't repeat the same mistakes over and over. Obviously, if they're the same mistakes over and over, then you do get, more emotionally involved, and those feelings of disappointment and things like that come. But it's incredibly helpful for you to express to them that you're not upset with them, that you want to kind of join with them and support them through that difficult time. Again, find out what happened, but they're going to feel very disappointed in themselves, and they're going to project that onto you.
There's a question about a family member who steps down from what I would assume would be a higher level of care while many of the warning signs are still present at home. One of the things that can be frustrating when you are a loved one of an adult is they are an adult and they have control over your access to the people who are working with them. So that may be information that we don't have because they haven't given us permission to discuss it. If you have that permission, I think sharing your concerns with the people who are working with them is appropriate. I think having caring discussions with them and letting them know in a caring way what you see and your concerns about what you see.
If I could just add to that too, I would say from the client perspective also that it's about what they're willing to engage in as well. So sometimes we can give a clinical recommendation, and kind of speaking of what Dr. Bozman was saying, but might say like, hey, I recommend you go to the partial hospitalization level of care, and the client might say, well, I'm really only willing to commit to intensive outpatient, which is 3 hours, 3 days a week. So that can be really different, like voluntarily what they're willing to do, just keeping that in mind.
There's a question that just came up, which I think is a really good one. Basically, about how do you support a loved one, but also be aware of your own limitations, boundaries, and that's really important. And I think if you look at like good customer service, we all respond better when we have asks, if you will, or we have things that we need. If someone comes up and says, look, here's what I'm able to do for you. I can do this and this and this. I'm not able to provide this right now. Let's help you get to somewhere that can help you. And so I think that same approach of being very transparent about what you're able to provide, that you love them, that you care about them. Here's what I'm able to do for you. I'm not able to do this. And so how can we help you get that from somewhere else, someone else? Oftentimes, if we're speaking about a loved one, it's probably a representation that there is, but they may be over reliant upon one person. Get back to Erin's discussion about, kind of the rescuer. It may be an indication that you're kind of taking on a rescuer role, and that you may need to kind of redirect them to, to sort of what can you do? How can I support you in doing that? If that makes sense.
I wanted to comment on, as a loved one, particularly as a parent, sometimes we asked ourselves, well, what did we do wrong? Or where did we go off track? I'm assuming you're all on here because you're concerned enough about the people you care about to take the time to do that. And this says a lot about you. You need to move past that. You're just a parent. You just did your best, right? The real question is, what can I do to help them now? And move past your feelings that somehow you let them down. You still have time to step up. And one of the things that I really want a message to be taken away from here is that people recover. And I know all three of us have received many, many messages over the years from clients who have gone through here, and they write us 2 or 3 years later and say, hey, just thought about you and wanted to let you know I'm doing really, really well. People recover. It is a process and it takes time, and they do need the people in their lives who support them to go through that process.
I just quickly wanted to answer a question that Walt put up here. How should you approach someone who doesn't know what their triggers are, someone dealing with anxiety? I think that's a really great question. And so just a quick go-to at HopeWay, we have a bunch of therapists who do the relapse prevention group. So I know it's a passion of Dr. Bozman's, but a couple of other therapists do it as well. When I do that group, I'll actually bring in what I call like a distress tolerance or coping mechanism scale, because you don't always know the trigger. We don't always have that. Here was the trigger and here's the coping skill. So it could be helpful just to have like on a scale, like from 0 being not triggered, what are my proactive coping skills, to 10 being, in very distressed, what are my coping skills, and kind of laying those out. So that way, if I just said, okay, in distress right now, if I'm an 8 out of 10, what are the things that typically work for me when I'm in that level of distress? Also keeping in mind that you're not doing like traditional CBT, like putting thoughts on trial and things like that when you're very anxious and in distress. The goal in that moment is to sit with the emotions and work through it. And then after it's over, you can reflect and think like, what was triggering for me here? Well, how can I handle that better next time?
So there's a question about what if me not meeting the person with the mental illness expectations, and that me not meeting those expectations becomes a trigger. The one thing I want you to understand is you have a right to set appropriate and healthy boundaries, and you may need help deciding what they are. It is extremely stressful to be a loved one of somebody dealing with a mental health issue. And a large part of that comes just from how much you want them to heal, and how frustrating it is to you not to be able to move that process along faster. If it's particularly stressful, the situation that you're in with somebody dealing with a mental health issue, it's not against the rules for you to go speak to somebody and get some help and help them help you and guide you through this process. But there are times when we just can't do. You have to also remember somebody with a mental health illness is not always thinking logically or rationally or even emotionally appropriately. So it is very important that you have a good sense of what your boundaries are and what is reasonable and appropriate for you to do and what is over the line.
I agree with you, Dr. Bozman, about the seeking of help. I think you don't have to be mentally ill, and you don't have to be significantly dysfunctional or anything like that to get therapy. In fact, some of the best therapy to be done is when people are very stable and well. I would encourage anybody here who's struggling and who's kind of looking through the feed of questions and answers. There are clearly some people who are in some very difficult situations. And so if you found that even remotely helpful, being here and just having us do this webinar, think of how beneficial it could be to have a mental health expert one-on-one with you, understanding the specifics of your case and of your loved one. So I often recommend at family sessions at HopeWay for people to kind of seek their own counsel if I feel like that's helpful.
I'm just scrolling through to see there is a question about I'm assuming your son, and that things get better and then the crap hits the fan. Learning resilience is part of recovery. Oftentimes clients come in with really not much resilience, and so very small things can be upsetting or get them off track. But resilience comes with practice, and it comes with competency and feeling like you have worked your way through that situation. When you have somebody with a very serious mental illness, this person mentioned schizophrenia in their question. That's a very serious mental illness. For me, and Dr. Marra, you may want to comment on that. It starts with medications. That's not necessarily true with every mental health issue, but that's a very serious mental illness, and you have to have a person who can think in straight and logical ways to be able to work through some of the things that were on the puzzle that I presented.
Yeah, I agree. You know, just to kind of name a few illnesses and states of illness that we typically think of as necessitating medication and sometimes indefinitely. Bipolar disorder and schizophrenia spectrum disorders tend to be the disorders that are the most biologically based, chemical based. They're oftentimes some of the most tragic cases because they sometimes don't show up until late teens, early adulthood. And you know, there was a question earlier about are there any breakthroughs in treatments or medications? And I think, unfortunately, in the medication world, no. I believe that there are many effective strategies and treatment programs and places and supports for people with severe and persistent mental illness like that. The unfortunate part about it is I don't think that our society values that. I don't think that there's been enough funding for that. I don't think there's enough programs like that. So there are programs and methods and things like that out there. You just have to kind of look a little bit harder than you should have to. Yeah, but the medication piece, I hope that people realize when you go to a psychiatrist, at least what I try to do and the way I was trained and the way that we operate at HopeWay is we want to be collaborative. We don't want to be the person that writes the script, slides it across the table and says, listen to my orders. I want to understand what you're looking for help with. I want to provide you information from my education and experience. And then I want to kind of collaboratively come up with a plan that allows us to kind of both feel like we are satisfied. Me, that you are on a medication, and that you're on one with the least amount of side effects that kind of is the best fit for you.
I would add, just even as the therapeutic approach, of course, when you're working with someone who's experiencing, I believe the diagnosis was paranoid schizophrenia that was thrown out there. Ooh, sorry, my light is, I've been sitting too long. When you're working with somebody who has paranoid schizophrenia, what they're experiencing is real, even though it's coming from a place of delusion or psychosis. So kind of joining with them on how their emotions are valid based on the experience that they are perceiving that they're having.
Yeah. Well, I think we're about out of time. I want to thank Dr. Bozman and Erin and Morgan Lyles, who set this up, and everybody here who came. I'll leave you with these words, and that is the fact that you're here, that you cared enough to take, an hour and a half out of your evening on a Thursday, means that you care a lot about your loved ones, and they're lucky to have you. And so please, I hope that you've learned something from this. If you have any questions, you can always reach out to us, and don't hesitate to reach out to other professionals if you need it. We'll go ahead and sign off for now, but I want to thank you guys.
Thank you, everybody.